female that presented with a bump in her serum creatinine from a baseline of 2.87 to 5.21 after her recent deceased donor renal transplant. She was receiving Prograf 7 milligrams EID, Celsep 1 gram daily, and prednisone 20 milligrams daily for immunosuppression. Biopsy revealed peritubular C4D deposition, acute tubular necrosis, and serology was positive for donor-specific antibodies. A diagnosis of humoral transplant rejection was made, and a course of treatment was decided on that consisted of solumetrol, plasmapheresis, IVIG, Velcade, and Solaris as it's presented in the table. So I'll discuss a little bit of background on humoral transplant rejection as well as the treatment regimen that this patient received. Humoral or antibody-mediated rejection is characterized by graft dysfunction that occurs over several days and usually occurs within the first month post-transplant. It occurs in about 5 to 7% of kidney transplant and accounts for 20 to 30% of acute rejections that occur in kidney transplants. The allograft injury and subsequent graft dysfunction is primarily by donor-specific antibodies against the HLAs on the endothelium of the graft. When the donor-specific antibodies bind to the HLA, it triggers the complement cascade, which begins with C1 and ultimately leads to the formation of the membrane attack complex, which consists of C5b through C9. The membrane attack complex is inserted into the endothelium and causes cell lysis. Additionally, the complement cascade causes chemotaxis of neutrophils, macrophages, and natural killer cells. When antibody-mediated complement type cytotoxicity occurs on a large scale, as it does with humoral rejection, it ultimately causes thrombosis and graft loss if it's not prevented. So a diagnosis of humoral rejection is based on 3 criteria. You need donor-specific antibodies. A serology should be positive for donor-specific antibodies. And a biopsy should reveal C4D and histopathological evidence of antibody-mediated injury. So C4D is an inactive product of the complement cascade, and it gets inserted into the graft endothelium. And so on biopsy, it can be stained and it can be seen with the staining. The evidence of antibody-mediated injury can be put into 3 classes. Class 1 is the presence of acute tubular necrosis with minimal inflammation. Class 2 includes glomerular inflammation, peritubular capillary inflammation, and microthrombosis. And class 3 includes arterial inflammation and organoid changes. The primary goals of treatment involve targeting the reduction and removal of the donor-specific antibodies and eliminating B cells and plasma cells responsible for the production of the antibodies. So there's a number of treatment modalities that can be used to achieve this. Plasmapheresis and IVIG cause antibody removal and neutralization. Mycophenolate, rituximab, and IVIG are anti-B cell therapies. Bortezomib is an anti-plasma agent. Anti-thymocyte globulin is an anti-T cell agent. And eculizumab is a terminal complement pathway inhibitor. There are a vast array of therapeutic modalities that can be used, but not one or one particular combination of therapy is effective in reversing or treating the rejection in all scenarios. There's not a lot of evidence to support a certain combination or a certain drug. So I'll focus on the treatment regimen that this patient received. Solumetrol is often the first line of therapy for acute rejection and started prior to determining the etiology of the rejection. High doses of steroids are used for immunomodulatory and anti-inflammatory effects. They affect all immune cells, so they're not specific for the humoral rejection and are often used in all types of transplant rejection. Major adverse effects with it would be hyperglycemia, hypertension, psychiatric disturbances, infections, immediately after the plasmapheresis, so this is more of a short-term treatment. IVIG is the most commonly used agent, and it helps replenish immunoglobulin depleted by plasmapheresis, and it also inhibits complement, neutralizes circulating antibodies, and decreases cytokine synthesis. IVIG has a black box warning for thrombosis, renal dysfunction, and acute renal failure. It is generally well tolerated by patients, although it can cause hypertension due to volume overload, headache, hypersensitivity reactions, and rarely acute kidney injury. So you need to monitor blood pressure, renal function, and urine output. Velcade and Solaris are target more novel pathways than other treatments. Velcade is a proteasome inhibitor, and proteasomes are responsible for the degradation of damaged proteins within a cell. So inhibiting the proteasome can lead to cell cycle arrest, endoplasmic reticulum stress, and cell apoptosis. Proteasomes are pronounced in plasma cells, and it's likely because of the high antibody turnover and high endoplasmic reticulum activity. So since plasma cells are responsible for producing the antibodies that trigger the complement cascade, Velcade inhibits these plasma cells and therefore inhibits the first step of the complement cascade activation. Velcade is FDA approved for multiple myeloma and mantle cell lymphoma, and adverse effects include GI intolerance, neuropathy, hypotension, cardiac, pulmonary, and hepatic toxicity, thrombocytopenia, neutropenia, and it's teratogenic. So you need to monitor CBCs and LFTs with this drug. Solaris is a humanized monoclonal antibody against the C5 protein in the complement cascade. It inhibits the C5 conversion to C5b, which is the first protein that makes up the membrane attack complex. So Solaris itself does not produce the donor-specific antibodies that are triggering the complement cascade, but it prevents the damage that is caused by the membrane attack complex. And it gives the other therapies time to reduce these antibodies that are triggering it. It's FDA approved for paroxysmal nocturnal hemoglobinuria and atypical hemolytic uremic syndrome. It has a black box warning for meningococcal infections, and therefore patients need to receive vaccination at least 2 weeks prior to starting therapy, unless the risks of delaying therapy are higher than the risks of in getting a meningococcal infection. So it's in a REMS program for this reason, and prescribers have to be enrolled. They must counsel patients on the risks and ensure that they're vaccinated. Adverse effects with this drug include GI intolerance, headache, infusion reactions, anemia, and hypertension. You need to monitor for signs of infection, especially meningococcal infection, because it's very high risk with this drug. The downside to using Solaris is its price. This entire treatment costs about $40,000, and Solaris, the one dose of Solaris the patient got costs almost half of that. So it's very expensive, and it's probably why it hasn't been used a whole lot to treat humoral rejection. So you can see with this treatment regimen, you're able to kind of attack the immune system on several different locations. The Velcade inhibited the activation of the complement cascade by reducing the plasma cells. Solaris inhibited the end product of the complement cascade by inhibiting the membrane attack complex formation. The plasmapheresis and IVIG were able to neutralize and remove the antibodies that were already formed. So our patient began to improve about day 5 of treatment. Her serum creatinine started to trend down, and she was able to be discharged after her day 10 of treatment with the Velcade. Does anyone have any questions about humoral rejection? Yes?
So this treatment strategy, kind of being involved in the background of transplant for a while, I've seen it kind of emerge and change. Where is this treatment regimen? Is it pretty standardized? Other centers are using this, or?
I would say no. There's a lot of different treatment regimens that I've seen in the literature, and there's really not a lot of evidence to support any of them. Most of the studies are case series, case studies. There's some very small studies that use retrospective controls, but there's really no controlled trials for any specific regimen at all.
Yeah, so Justin and I were talking about this earlier in the week, Solaris. How many, if we're going to use this on rejections like in the last couple of months, right?
Right.
How
Yeah.
many rejections do we have here on a given month?
Well,
Do y'all know?
These are the first two moral ones that I've had since I've been in this position, so we don't have this very much, we kind of have two in the same week. Generally, we have more T-cell rejection, which is when away, they come back, 2 to 3 years, a lot of times for the uncompliance with medications. This is actually very rare.
Yeah.
So this is a Dr. Coco and Dr. Wagner thing they want to try out. But you found, Justin did that thing, so come up with
right,
something.
okay, so I found a study using Solaris. It wasn't in rejection, it was in patients that needed emergent transplant, so they weren't cross-matched to their donor. And so we're very high risk for rejection, and we're actually giving Solaris. They had, the control was retrospective patients that were not cross-matched and had received kidney transplants. But the patients that received Solaris had better outcomes than the patients as far as acute humoral rejection goes
But it was-
than patients.
Pre-transplant like time.
Right, right. It was pre-rejection. So this is more post-rejection. We're treating the rejection. And that study was more preventing rejection. And when they biopsied those kidneys, they did find that the same number of patients had elevated donor-specific antibodies and C4D deposition in the kidney. But the patients that received the Solaris did not have rejection versus the patients that did see rejection. So that was the difference.
Weren't those numbers pretty dramatic?
Right, it was like
7%.
It was like 7% of patients that got the Solaris did not have rejection versus about 50% of the patients that didn't get it had rejection. So it was a big difference.
Got one more question, Jessica. So I know in the past too, with Dr. Lou, we haven't had one in a while, but it's been when it's like a mixed oral cellular rejection.
Uh-huh.
We've used alemtuzumab or camapab. Is there any role in that for these patients?
I don't believe so because CAMPAP works on the T cell, and since this is not T cell mediated, I don't think that it would have effect. But I know that antibody mediated rejection often occurs with cellular rejection. So it's common to have both, but
That's where I've seen it with the
Right.
combination. Thanks.
Okay.
Do we know anything, just curious, do we know anything about the kidney? Was this
About the
like a
what?
Kidney, was this an expanded criteria? The post-cardiac death,
As
brain
far as the
death?
kidney goes, I don't know anything about the kidney itself, no.
I'm always curious about the T-cell stuff, because I mean, ultimately, if you think about it, as it comes to like the CAMPAP, particularly, this all starts with the helper T-cell. So, I mean, the antibody's gonna come from somewhere, and it's that T-cell mediated, something that's going on. Complement's cool, but complement, I don't think we know a